5-year plan that we published recently. Some of you may have had chance to have a read of it. It's quite a hefty document, lots to go through. So hopefully this kind of will bring it to life a bit, just talking to you about some of the key component parts, what we're trying to achieve, and importantly, getting some of your feedback in the room really, and some of your questions and observations will help us going forward. I think it's fair to say, and after 20 years of working in the NHS, it's quite difficult to write plans like this, but it's even more difficult to then actually translate them into delivery and actually making change happen on the ground. So that's kind of where we are now, where we've got a plan, we've done a lot of engagement, we're carrying on with that engagement, obviously, like we are today, but we do really want to now start taking forward some of these strategic aims and priorities that are set out within the documentation. So what I'm going to do, and then I'll hand to my colleague Craig to get into a bit more of the detail. And Craig has done a lot of the legwork with our team within the ICB and with other partners to really pull this together. But between us, we're just going to set out a bit of context, not assuming great deals of knowledge around this area. So just sort of bringing everyone up to speed together. And then, once we've done that outline, talk to you a little bit about what this thing is all about. Be great then, as I say, to get any questions or observations, and we'll go from there. So I'll just move the slides forward. So the first thing I suppose to say, and this will be familiar to some people as well, that we very much not started from a blank sheet here or started a process again. You may be aware that we've already got our integrated care strategy as part of our integrated care system for Derby and Derbyshire. And this particular strategy was set on the premise of 3 really important areas, looking at the life course of an individual or a citizen in our population. So when someone is born and the start of their life and through their childhood, really important around starting well in terms of key health outcomes. And then through the course of someone's life, as they sort of get older, staying well, having that healthy life experience for as long as possible, making healthy choices, being protected from harm, all of those really important things, and having that high quality of life. And then as we get even older and sort of come towards the end of life, really making sure that people age well, that they feel as fit as they can, that they're safe, that end of life process is as good as it can be for themselves and for their families. So really sort of looking across the whole of someone's life, making sure that we've got really key outcomes and deliverables for our local population. So we've basically built on that. And we are sort of pitching this as an NHS plan, not that we're saying that the broader work with our partners isn't important. Indeed, it's really important, but the NHS also needs to be really clear about its contribution to delivering the integrated care strategy, and also what those particular things that the health service will do locally to advance in those key areas. So this is what we're calling our joint forward plan. It was a title that was created by NHS England, who is our regulator as an ICB. But I think it's important in setting out that it's really clear about that 5-year period moving forward. Where are we going to be and how are we going to deliver some of these strategic aims? So we've effectively set it out across 4 key areas, and we'll get into more detail, I'm sure, on this later. But something very much about the input from a prevention perspective. It's not a new concept to say that, if you can get more upstream and prevent things from happening in the first place, and that's obviously better for the individual, but also better for the services and the resources we've got, etc., in terms of helping people to manage ill health that hopefully doesn't occur or is not as progressed as it could be through earlier sort of detection, prevention, etc. Also, an area which we know up and down the country is a massive priority, but no less in Derby and Derbyshire, is around our health inequalities and the outcomes that different people experience, sometimes dependent on whereabouts they live within our county or city, or through other factors, whether they're socio-economic factors, other sort of factors that have a direct impact on people's health. And obviously that's not fair, is it, that those sorts of factors then can result in either better or poorer health outcomes for people. But it's really important that we can do what the best we can to reduce some of those gaps that we've got in a whole sort of raft of different sort of offers, if you like, from the NHS. We also are really focused on our people in terms of our staff and the people who work on the front line and really help to drive these improved outcomes for our population. So we talk about a sort of a strength-based and personalised approach that our teams can have with patients and with citizens in terms of how care is provided, which is also another important part. And then finally, something which often doesn't feel so tangible, but it is really important about the sort of join up and connectivity across different organisations, across different services. I'm sure people have got experiences in the room when you've gone to a particular part of the health service for care, and then you're handed over to someone else, and sometimes you can feel like you're a bit sort of passed around between different organisations and different pathways. How do we better join some of that up so the experience is better, it's more efficient, and that those sort of services and outcomes are talking to each other? So that's another key area for us as well. So we know we have a number of challenges if we're to overcome some of the sort of things that we're experiencing now, and to get to that space of the joint forward plan of delivering some of those outcomes. So I'm not going to read all of these out, you can see them for yourself, but we really do have that mix of making sure that we do look at inequity that I've just described, thinking about the demography as well. We have an aging population. We also have people with more long-term conditions and people who need different types of care at different stages, so that also has to be played in. And also thinking about the expectations that the public rightly have about how they can input into and have control over their own healthcare is another key part of our plan. But we know we've got our constraints. There is not a sort of endless pot, if you like, in terms of some of the resource we've got, whether that's from a money perspective or from a workforce perspective, or even the sort of buildings and estates we've got to house things. So a lot of constraints that we have to also put into the mix, really, and balance with what we can really achieve. And then there's often very exciting things from a technology and sort of data and digital perspective, but how do we actually use those innovations so that we can actually maybe do things a bit quicker or do things more effectively? And how do we get involved with all of that and pull it all together? So lots of challenges to grapple with, but equally opportunities obviously come with challenges too. So I suppose just a bit of a reminder, and I've mentioned about health inequalities, but I always find things like this very, very stark and an important yet sobering reminder, really, of why we're doing some of these things. So you can see some statistics here around both the life expectancy and also the length of time that someone can expect to be healthy within their life for both males and females within the city and across the county. And if you can see the numbers, the numbers in brackets afterwards show the gap, or if you like, the difference between the highest and lowest sort of experience of individuals in terms of that health inequality gap. So the overall strategic aim is obviously to close that gap, so that if you are a man born in Derby, you wouldn't expect to have a different life expectancy or a healthy life expectancy to a man born in Derbyshire. And equally, obviously, we look across males and females at those differences. So it really is about closing some of those gaps and being able to show in our data in years to come that actually we've sort of managed to close those gaps and really improve outcomes where we can. Just a little bit of a sort of a positioning slide here. I mentioned about the integrated care strategy, and obviously today we're talking about the joint forward plan, but also to remember that we've got some other connecting strategies in our system. So we also have important work with our health and wellbeing boards as well. So they have sort of joint health and wellbeing strategies. So both for our city and county, we have been working really closely to make sure that we align our plans as far as we can. So if a member of the public or a key stakeholder is reading our plans, they understand how they all connect to each other. We also have a lot of individual organisations who indeed have their own plans and strategies, and we've done a lot of work as well to connect those things together. So that's just to show that this is not in isolation. These things all kind of fit together. as an integrated care board, and obviously myself and Craig are from the ICB today, and you might recall that, you know, before ICBs we had CCGs and lots of acronyms in the NHS, but we had the clinical commissioning group. So an ICB is different to a CCG, and one of the differences is about being a far more strategic organisation, and this being more strategic is really important to make sure that our integrated care strategy and our joint forward plan can be delivered. So what this slide shows is just a number of the functions that the ICB is responsible for, but demonstrating that those things on their own, whilst they're all really important and we need to play a leading role in, they're only going to be delivered as well as the partnerships and that interface that we've got across our partnerships. So whether that's our broader integrated care partnership itself, whether that's working with our local authorities, we have our places and our place alliances, where you've got your real local communities who are very close to their local population and they know best in terms of what the needs are, what the service needs are, and how we best come together. And then we've got some emerging work now about how providers collaborate differently as well, particularly thinking obviously at that place level, but also at scale as well, where there might be services that we can pull together and work differently. So all of these things need to come together to ensure that we can really deliver the plans that we've created. The final slide for me before I hand over to Craig to get a bit more into what is set out within the joint forward plan is I suppose just that reality check as well. I mean, I talked before about constraints and that, you know, we don't have endless resource to do all of the things that we might want to do. But we also have this, as we described, the sort of the balancing act. So we are absolutely trying to sort of tip the scales, if you like, to be more upstream, more preventative, and, you know, that sort of primary, you might have heard about primary prevention, secondary prevention, and really, as I say, that sort of more upstream approach. But we have to balance that with, you know, we often, particularly, you know, we're about to go into the winter soon. The weather's telling us we're starting to get towards that time of the year. We often have sort of operational pressures, things that on a day-to-day basis really do consume the time of our clinical teams and of our organisations trying to deliver good health and social care and broader support to our population. So it's constant moving of the scales, really, of saying, how do we do the upstream stuff and how do we get more into that and make sure what we're doing now is contributing to that for years to come and seeing those outcomes improve. But also a reality that, you know, we are still recovering from the pandemic. We've got, you know, people waiting longer than we want, for example, for elective care. We have fragilities in primary care that we're doing our best to support and make sure people have access, etc., etc. So lots of things to balance, really, which I think is described within the joint forward plan, but we mustn't lose sight of the constant sort of tension, I suppose, between sorting today's problems, but also making sure that tomorrow's are improving as well. So lots to do, and would welcome people's thoughts on experiences in some of those areas. So I'm just going to move on, and hopefully Craig is there. He's got a couple of slides that he's going to talk through, and then importantly we can get into questions and conversation. Thank you, Craig.
Thanks. All right. I guess before
Mark, did you have your hand up? Yeah. Sorry.
Yeah, it's just we have a question, but I suppose it can wait until after Craig, unless you want to field it now.
Yeah, we'll wait until the end, I think.
Yeah, absolutely.
Yeah, thanks, Mark.
Okay, thanks, Mark.
Thanks, Craig.
Thanks, Zara. Hi everybody. So yeah, my name's Craig. I work for the ICB, and I've been working with colleagues probably over the last few months to produce the joint forward plan. So I appreciate this slide is very, very wordy, so I'll try and kind of summarize it in more straightforward terms. So effectively, the intent of the joint forward plan is, I think as Sally said at the beginning, it is about setting the NHS on a different course. And by that, what we mean is that the fundamental operating model, i.e. how the NHS operates, we recognise has to be completely different in the next 5 to 10 years compared to how it has operated certainly over the last 5 to 10, 15 years. And so the kind of key features of this sort of new way in which the NHS will operate is that we think it's really important for the service to be becoming more preventative in nature. we fully recognise that the care offering to people has to be absolutely more personalised. There are some really good examples of great practice in the NHS which actually involves people in the design of the service and ultimately in the delivery of it, and we need to be doing that much more often. The third aspect of our intent is about becoming truly intelligence-led. So the NHS is perhaps one of the biggest organisations in the public sector that has probably more information at its disposal than any other. And I guess it's valid to say that we are not making effective use of that information to help make better decisions for people and their families. And I guess the fourth aspect that kind of like wraps this all together is for the care offering to actually become much more integrated by design, so that this constant palming off between services is actually designed out. So kind of our assessment has been quite an honest one. I guess colleagues in this room would kind of recognise some of the features of how the NHS has operated in the past and what needs to improve, and we recognise it, and the whole point of the document is to set us on that course. I guess the second point I want to talk about is that we recognise that clearly the greatest asset in the NHS is the people who work in it, and the challenge that we set ourselves is, or one of the tests that we will set ourselves is actually the people who actually know what actually improves care, people who actually deliver the services. Are we actually giving those people the control, the resources, the assets to try new things, to fail quickly, to be more flexible, and to link together? Because I think one of the features of how we've set up the NHS and operated it is that it is not like that. So apologise for the terminology, but we talk about this new form of organisation of professionals, and it really matters because it's only through giving people who work in the NHS the proper accountability and responsibility, but actually the resources to make improvements that makes the difference. And I guess the third thing to say before then talking about some of the action that we'll take is that we fully recognise that there's some big structural things that need to happen, some of which was within the control of the local NHS in Derby and Derbyshire, and some of it clearly is within the control of the national agenda. So we have some choices to make about the type of workforce we invest in. We certainly have local discretion, quite a lot of it, in terms of how we invest certainly financial resource to support that new workforce. And we also know there's a big structural change in the nature of care that we deliver. So, for example, we've talked a lot in the past in the NHS about moving provision from the acute end of the pathway to the more primary and community preventative space, but actually have never really done it wholesale. So again, that's another test of whether we're changing, is to actually over the next 5, and to be honest, more than 5 years, we're actually shifting deliberately resource, workforce, service provision in the spaces that will actually make the difference. So the way in which we've then sort of thought about, well, how do we actually bring this about? And perhaps the next slides is probably an easier one to navigate than those small circles in this one. So effectively, what we've decided as an NHS, working with all the partners within it, but also colleagues outside the NHS, is that we will be allocating more resource to activities that will prevent, postpone, or lessen the complication of disease. So more resource for prevention. We don't have a view right now about what the right level is. We'll talk about that in a minute. But fundamentally, I think it's really important to say that a guiding policy of the NHS over the next 5 years is that we will be allocating more resource to the important agenda around prevention. Whether that's primary prevention, secondary or tertiary, there's a debate to be had, but fundamentally it's important to say that straight off the bat. Secondly, we want to be giving more people greater control over their care. So all of the action that we develop will be giving people more control over their care is something that we value. So it'll be a key test for us. So, for example, to what extent can we fully utilize the new information technology that's available for people? So using tech to help people book appointments easier, giving people greater access to their health records, so that actually people know what's being said about them, and actually they're going to have some role in coming up with their own care treatment plans. So there's some practical things that we think we can do over the next 5 years for people to get more control, because it's only through people taking more control over their own health and the services that they interact with where we'll get change. The third aspect, and as you can see on the slide here, is about empowering our teams. So I guess the action that we'll be taking in this regard is basically saying, well, what gets in the way of making positive change locally? So the kind of barriers, whether it becomes whether it's in the space of well, my organization does it this way, that organization does it that way. Well, we'll get rid of that and we'll focus on the things that will actually make the difference, giving people greater control to make the changes that are necessary. So actually empowering our teams, giving them resources to deliver change with people is something that we really will be progressing. We can't get away from the productivity and efficiency agenda. Clearly, I think there was right at the beginning of the presentation, Zara talked about this, and it's a national thing as well as a local thing, this kind of demand versus supply. We haven't got enough money to keep the thing functioning. So clearly our view is that the new operating model should be cheaper in the long run. If we're preventing disease and complications, then actually we will be making the whole offering much more economically viable. But actually, and again, coming from the space of kind of a candid kind of view about where we are, we know that how we deliver care right now, there's a litany of examples about where we're duplicating things, where people are getting various assessments in different spaces, redos, readmissions, the whole shebang. So people call it demand failure, but actually that's the kind of type of demand that we've got to be taking out of the system. There's demand that arises because of failure of process. So actually that will give us certainly quite a lot of scope to make financial savings. And then fifthly, the key sort of guiding policies about this kind of intelligence. So actually we say a lot in our JFP about the need to value intelligence, data, so that we can be more scientific in how we make predictions, so that we can really use our data to understand and work with people to understand those people who are really most at risk of developing certain diseases, certain conditions, people who are perhaps not even accessing services, and based on our understanding of their needs, we might actually be more proactive. So you can't do that without a very good, well-developed intelligence function. So that's certainly something that we in the JFP talk a lot about in terms of taking positive action to improve that over the next 5 years. So they are kind of like the 5 core actions that we'll be taking. I guess the next slide then gets into a little bit more detail, and again, very wordy, but clearly there's a lot to do. So we've kind of prioritized which one we will focus on first. So we think that there is value in drawing together all of the right people and intelligence. So we talk about allocating more resource to prevention. So one of the things that we'll be doing now, which we are doing now, is thinking about, well, what type of prevention then, for what type of conditions, what will make the biggest impact in the shortest amount of time. So for example, do we focus on preventing MSK conditions? Do we focus on cardiovascular? What's the intersection between different diseases? So there's a hell of a lot to do, but what this slide does here is show you some of the steps that we're taking now to get to the point where we can make some really good decisions about what type of interventions we want to be spending more money on to give us that medium and longer term benefit. Clearly, we also recognize that it's not just about identifying things that we want to do more of. We fully understand that we need to be then thinking about the things we have to be doing less of and decommissioning. So actually developing an approach to disinvesting in certain aspects of provision needs to be thought through. We are, as you can see in this document, working on the early aspects of that. Will take some time to develop, as you can imagine. So it's a balanced approach. We identify the things that we want to spend more money on, and we've got to pay for it by disinvesting in other things. So that's kind of the first tranche of action. The second tranche of action is really honing in on that whole efficiency agenda. So this financial year, we've got a very difficult efficiency target to deliver, quite a significant amount of financial savings. So that we don't start from a blank sheet of paper. We have quite an advanced and well-developed program of change to try and deliver that level of saving. But what the JFP does is give us, I think, a greater impetus to think about where there is actual waste in the system. So, what things can we do in the next 12 months that effectively doesn't really affect patient care? It's about process redesign, making sure that we design out duplication so that we can save some money and we can make the overall experience of patients much better. So certainly our provider colleagues own that space. So it gives you hopefully a sense of the work that we're doing to try and sort of translate what are kind of laudable aims in the joint forward plan into a program of work that we can deliver, with NHS partners, with local authority colleagues, but also more importantly with communities over the next five years or so. So I hope that's helpful. And I think the next slides are is it questions? I think yes. Any questions? So over to you, Sally.
Brilliant. Thanks very much, Craig and Zara. That was a great overview of the joint forward plan. And I can see there's lots of questions in the chat, which is great. So this is the next part of our session, is the question and answer with you both. So I'll just go to Mark to sort of point in the direction of the first question. That would be great, Mark.
Yeah, we have loads, so it may take a little bit of time. So from the top, Stella dropped the question: cancer, kidney disease, diabetes are amongst the most costly to any health provider. Will these be prioritised on prevention measures?
Are we taking one question in turn, Mark? Did I just come in and just answer? Is that okay?
Yeah, that'd be great.
Great, thank you. So I just want to make sure I got the format right. So yeah, no, really important question. So there's a range of areas, and absolutely, you're right, Stella. Those areas, absolutely, from a person's perspective, but also in terms of a resource intensity perspective. So there are some key areas, and I think there was, maybe to try and cover off, I saw another question in the chat that said, what's PHM? So population health management is an approach which is being developed by the ICB in partnership with others as well, about how actually, almost what's the approach to taking these key areas of disease or key outcomes that we want to improve, and actually how we do that from a population health perspective. So in that vein, then absolutely those areas are key. We're looking at where we can invest differently around that primary prevention side of things. So things not happening in the first place, also secondary prevention too, where outcomes can be improved in terms of interventions at an earlier stage, but areas including cardiovascular disease, diabetes, some of the respiratory illness that we see in our population, as well as when I mentioned at the start of the presentation about from a children's perspective, so that sort of school readiness and getting people ready at that age for that stage of life. So that's another key priority for us, as well as at the end of life, thinking more about sort of the older population, preventing falls, frailty. So there's a whole basket, I suppose, of things, but you're absolutely right to draw out those areas as well.
Thanks, Zara.
Okay. Yeah, the next question then was from Valerie. She was the one that asked about PHM, but in the same question, she also asked, will services still have to be put out to tender?
So I'll try and give a short answer to something which is probably a bit more complex than just a couple of sentences. But I mean, in terms of tendering of services, there are particular sort of procurement regulations and things that we do have to follow, and that there's lots of debate about whether some of the policy and requirements might change over time, and then that obviously changes some of the rules about what we need to do. But what we're certainly trying to do at the moment is within the rules of how we can operate is working with incumbent providers, with partners and stakeholders about how best do we sort of deliver our services, so it's not as transactional as it probably was a few years ago. So yes, there are still requirements to tender services in line with some of those regulations, but how we go about doing that and who we engage with and how we get all of the relevant inputs to make sure that we've got the right service models, etc., is is a different way of sort of working in terms of that integrated care approach.
Okay, the next question is from Pete. He asks, what do you think are or will be the biggest challenges that may prevent your plan in achieving the outcomes you desire?
Gosh, no, that I mean, that's a very very interesting question, isn't it? Because I suppose there are lots of things that can get in the way of the best laid plans. Craig, by the way, feel free to come in as well if there's things that I've missed. But I mean, if I say one of them, I mean, definitely the thing about the short term sort of focus on things that we have to do, there's a lot of, quite rightly, what are we doing today, this week, this month, this year, to really address some of the challenges that we've got in healthcare. Some of those things that we do aren't necessarily the things that we need to do for the longer term, and to see those outcomes that might take 5 or 10 years or longer sometimes to really show that improvement. So I think there's something about how do we distribute our resources, our time and our energy and efforts into both today's issues but also those others. That would definitely be a challenge for me. But go on, Craig, sorry, do you want to come in?
This is a really difficult question, but I guess for me, and this is not just me, my view, it's probably a view that you would agree with, which is so it's easy to say we will change the operating model. It's easy to say that we want to be more preventative, but there's an ingrained culture clearly in terms of how we've been working for the last 70 years. That's a fact, and actually changing that culture is really difficult, because there are a fundamental set of power dynamics that have been established that are really difficult to redefine and reorientate. So I guess it's that kind of, the key challenge for me is how we can show people, and when I say people working in the NHS, that actually by changing practice, by changing how we design things, by changing how we actually interact with patients and actually involve people who receive services much more seriously in the process, that actually you start to change that culture and show people that there's benefits in doing that. And I think that's the key challenge for me. Things like money, things like workforce are kind of constraints that we've always worked with, and you, like any public service, you adapt and you flex according to the kind of the inputs that you're working with. But the fundamental thing that makes things work is the culture of an organization, the culture of a system like the NHS, and changing it to do the things that we've talked about is incredibly challenging. But there's a test that we have to pass, because if not, we won't make progress.
Okay, the next question is from Stella. And she asks, how does the ICB envisage coordinating where residents are treated in other regional areas, and will this be reflected in funding availability?
I'm happy to come in on that, and Craig, if you wanted to add anything. So, I mean, we do work. I mean, we've been talking, haven't we, today about specifically about the areas under our remit, if you like, as an ICB and a broader integrated care partnership for Derby and Derbyshire. Clearly, you know, in terms of flows of where people live and sort of over the border going into other counties and indeed other parts of the country at times, you know, that there's care being delivered in all sorts of areas. I mean, we do have very good relationships, if for example, you know, across our East Midlands partners. So we're talking together about particular services, how they can be best delivered in the future. So I suppose we've got, I suppose, more direct control, if you like, within our own population about the services that we commission and how they get provided. But we also do very much link into other areas, you know, across the region and further afield as well, as to how we better collaborate. So I think in answer to your question, Stella, that is all included in our work. Although this plan today that we're talking about is obviously the specific sort of Derby and Derbyshire version. Other systems also have their joint forward plans, and we obviously link into those as well to see that if a Derbyshire patient goes and gets some treatment in Nottinghamshire, that, you know, they're still getting good care and good outcomes that, you know, we're all aspiring to deliver. Craig, did you want to add anything?
Yeah, no, I mean, that's the point, isn't it, Zara? So I think it's more of a point of assurance, really, that we haven't sort of worked to some sort of arbitrary set of parameters, which is, well, the Derbyshire population is defined by, you know, the providers who operate in Derbyshire. It's about the population and where they get care. And we know that circa 20% of our population receive their planned care outside of Derbyshire. You know, a significant proportion of people who are living in the north of the county, and certainly to the east of the county, east of the geography. So yeah, point of assurance, this isn't just about the sum of the providers in Derbyshire. It's about the population and where they need their care. So.
Okay, the next question is from Stella as well. She asks, how do you envisage the digital rollout will benefit patients when there is not one digital system in place used by both primary and secondary care providers?
Do you want to go on that one, Craig?
Yeah, so that's so the NHS has got a, let's say, a kind of checkered history when it comes to using tech to make things better. But actually, one aspect of true innovation that's actually in place now, and that will be progressed certainly over this 5-year time period, is the rollout of the shared care record. That's how it's effectively a record that any clinician working in any part of the system, whether it's primary care, acute care, mental health, or indeed actually increasingly in non-NHS services, can see the same information, so that this sort of siloed approach to information management is fundamentally eradicated. So we've introduced a shared care record. I'm sure the big colleagues on this call who have got views of it, but actually creating the mechanism to share information about people and their conditions so that the right decisions can be made with them and about them is something that's happening now. So that's really, really important. I think the thing that perhaps needs to develop from that is then how citizens can access that information, and so that citizens can then also add information into their own record about their conditions. But the fundamental first step of, okay, let's link information systems together and actually let's link the records that people are seeing, is something that we've taken. So yeah, it's a true enabler to change, but we're putting our money into it. There's a lot of money in that space, and there's a really quite well advanced program to deliver that.
Thanks, Craig. I think maybe before we go back to the chat, Mark, I'm conscious Peter's had his hand up, so I think we'll come to Peter now, if that's all right, Peter, and then we'll go back to the chat messages.
Craig mentioned NHS access to people and the importance of giving resources to those people to effect change, make a difference, empowering our teams was your phrase. But you didn't mention the commitment of the ICB to co-production in the progression of that change. Another speaker has mentioned the importance of involving those who receive services actually in their development. And I just wanted to check that you in fact giving that importance in this development to involving people right from the very outset, and not later on in the process once the NHS staff have actually developed a series of options which they might consult about, which lacks often the essential elements that which involving service users from the outset might have made.
Coming on that, I completely agree, Peter, and apologise for not emphasising that enough in the presentation. But I just fully agree with you. So I guess the point of assurance that I can give you on that is that we, the work that I mentioned that's just started now about, okay, so how can we create a really transparent and objective assessment about what we value, what we don't value, what creates benefits for people, is something that isn't just an NHS clinical view of the world. We have to involve people who actually receive the care and who are managing these conditions and living with these conditions on a daily basis in that process. And I think, me saying that's really important. And actually, that's a test that the public can hold the NHS to account to. So, for example, we had a really interesting conversation in the meeting this morning about musculoskeletal health outcomes in this county of at best variable. And actually, we talked about a new approach to creating a team of people who can connect to come up with solutions about improving, and people with lived experience of MSK health are a core component of that, Peter. So I guess all I can say is I fully agree with you, and actually our intent isn't just to have this done to people. We have to involve citizens in the process of effectively prioritization, and that's really important.
Thank you for that commitment, Craig.
Okay, should we go back to the chat? We've got about 12 minutes left, so I know there's loads and loads of questions in the chat, which is brilliant. I don't think we'll get to all of them, but I'm sure Mark will try and pick out some of the key ones now, and obviously any that we don't get to, we will make sure we provide a response, and we'll upload that onto the engagement platform, okay, at a later date.
Yeah, they're all very important questions. There's only 6, so brief answers might get us through them. So Nick has asked, you talk about the fundamental aspects which need to be addressed: the type of workforce, how we invest financial resource, and the nature of care we deliver. How do you perceive the place of the VCSE sector within this, i.e. not just within the NHS as it presently sits? And for context, Nick currently contributes within the VCSE Alliance as a social enterprise, trying to work in partnership with health and social care. Yeah,
Nick, I think you've hit the nail on the head. So in a similar way to, based on what I've just said to Peter, so the voluntary sector has been in the shadows, I think, in terms of its role in terms of how it can influence, how it should be influencing certainly the NHS commissioning process, but also it as a delivery partner. So I fully agree with you, because I think that, and this is a really important part of the Joint Forward Plan, in that, we fully recognise in the NHS that NHS healthcare contributes only about 20% of the health gain of an individual population. There's 80% of factors, largely actually the control of the wider public sector, that make much more of an influence on people's health. And actually the voluntary sector need to play a greater part. We need to be effectively kind of powering it up to help us in that endeavour. So I guess all I can say right now is I agree with you. And again, another test that the voluntary sector can hold the NHS to account to is to what extent it is involved, not only on the delivery side, but actually how can we get the intelligence and the value that you create working with people in a much more intense way than the NHS does, so that we can develop services and improve services together. And against another test that we can hold ourselves account to.
Okay, Valerie has asked, why will this reorganisation work when many others haven't? How will NHS get other key influencers to change, for example, income, housing and so on? Does organisation of professionals include all NHS workers, such as cleaners?
That's a very long question, isn't there? There's lots of things in there, Valerie, I think, but really important. So I suppose it's not necessarily seeing this as a reorganisation in my mind. I think we've probably been clear for quite a while that we need to do things differently, but it's articulating exactly what that is, and then importantly how we will go on to do it. We're not naive, though, that obviously we talked before about some of the constraints, some of the broader things that we need to do and influence. So this is where, you know, we're setting this out as an NHS plan, but it's still part of that broader integrated care strategy delivery. And indeed, I think I mentioned earlier about our health and wellbeing boards, who have responsibility for things that I think you've mentioned there around, you know, for example, housing and some of those broader areas that have those impacts on healthcare, and often have bigger impacts on healthcare than some of the things that the NHS can influence and control. So it's quite hard to answer the question, because it's fairly complex. But I suppose what, you know, if it's more about sort of what's going to be different, and how, you know, how sort of confident are we about, you know, being able to do some of that thing, some of those things. I think it links to what Craig said earlier about sort of cultural change. You know, it's quite hard, isn't it, to encourage people to work differently, but we've got to keep working on that, and that will take a lot of time to embed, but showing through good examples of how things are working and making that happen. But ultimately, I think it's, you know, the key from taking a plan into delivery is being really quite specific about the things that we can do, and in our own sphere of influence, and showing, you know, the public, our key stakeholders, how we're making progress on those things year on year. But also the strength of our partnerships, you know, particularly if I say link back to the health and wellbeing boards that are responsible for some of the wider determinants. How do we work better together to make sure that the NHS is delivering its part of the equation, and indeed other partners are delivering theirs, because obviously both need to happen in order to deliver those outcomes overall. So a very, very sort of probably sort of long-winded answer, but I think it's quite hard to answer succinctly. But if we're clear on the deliverables, we work on the cultural side of things, and we've got those strong partnerships, I think things can only be different and more improved to where they've been historically.
Yeah, and so just to come in on that as well. So I think hopefully when you read the joint forward plan, is that we are really quite clear about where we've come from as well. So you learn from history, don't you? You learn effectively what the impact of decisions that the wider public sector has had to make in the really difficult sort of fiscal environment that we've been dealing with, certainly since the pandemic, but certainly actually since the sort of crash, is that those things have had impacts. So we're not naive to think, well, actually it's all going to be rosy. We really understand the baseline to which we're working to, which in reality has been in some cases a deterioration in health due to some of those big drivers of health, which is around the wider socioeconomic landscape, and we know where we've seen deterioration. So yeah, I guess it's another point to say that the kind of improvement that we want to make from over the next 5 years actually probably will get us back to where we were back in the early 2010s in reality. So yeah, certainly not naive to think to understand the kind of size of the challenge that we've got, but yeah, real intent to get there.
Okay,
Thanks.
Pete has a question. If the focus will be on prevention, will there be strict measures taken with patients who avoid prevention, obviously, such as a COPD person continuing to smoke knowing the damage it causes? And will care be refused to people who actively work against preventing their illness?
So I guess the kind of short answer is absolutely not. I don't think we're in the space of that, because I think we kind of fully recognise that the decisions that individuals make are kind of driven through a number of things that are without their control. There's a fundamental socio-economic environment that certainly the most deprived people live in, where their choices are quite limited. So we're certainly not in the space of making value judgments about people's behaviour. Absolutely not. I don't think that's the business of the NHS to do so. That's the job of politicians to make. But fundamentally, we've got to have a more sophisticated understanding about why people make the decisions they're making, which is largely shaped through the commercial aspects of the economy and the wider socioeconomic situations that people live in. So that's what I would say on that point, if that's helpful.
Still got some time. So Pat has asked, what about the abuse of services by patients? That is the huge number of DNAs, did not attends, in all areas.
So abuse is a really interesting word, because I guess, do we really understand why patients aren't using services and why people maybe not attending appointments? I'd say we don't actually understand the drivers of that. So it goes back to what I was saying before, in that if we actually talk to people about how services can actually fit in with their lives, as opposed to people having to kind of completely rearrange their own lives to fit in with the NHS's way of designing services, is something that perhaps might have a positive impact on DNAs. I don't think people are willfully not attending appointments. There's a reason why people don't attend appointments. And I guess the challenge for us all is, do we actually understand why that is? There might be an element of waste in there and people kind of overtly doing it, but my gut would be that's a very, very, very small proportion. It's probably more about the fundamental service design doesn't fit in with people's lives fundamentally.
Okay, just two more to go. I think we can fit them in. Peter has asked, the key elements of the joint forward plan are laudable but require resources that will pay dividends in the future. For example, focusing on prevention. How do we prime the resource pump when coalface practitioners do not have the resource today to provide an adequate resource service?
Sure. Craig, you can run it.
Yeah, so I'll start, and maybe absolutely, that's the most trickiest part of this, isn't it? So let's start at the macro. We've got a lot of money in the NHS, spending about £3 billion a year. So in total, we've got a lot of money to spend. The point is well made, is that that's been spent on stuff already. So changing something means that you either got to create more money to pay for it, or indeed you've got to reinvest. I guess the challenge is this, though, isn't it? So changing something, I guess, kind of requires the health system, to accept short-term, potentially negative impacts about moving to that change, so that actually in the medium to long term, the benefits can outweigh the costs. And that's the massive trick that we have to play in the NHS every day, let alone in this 5-year plan. But fundamentally, that's how it will work. So for example, if we know that we've got to spend more money on preventing respiratory illness and the complications of that, well, clearly we have to be managing right now the complications of that respiratory care. So to what extent do we slow down that care, perhaps absorb people having to wait long for that care, so that actually we can get that service on a much more sustainable footing for the medium to long term? That's not easy. That's really hard. And going back to what Peter was saying, you have to involve people in that decision, so that actually you understand the trade-offs that you're making. But that's the challenge. But understanding the detail of that is something that clearly we'll work through as we develop this implementation plan. So Zara, I don't know if you want to come and.
In the interest of time, I know colleagues want to finish on time, so I won't, but we can provide extra detail outside if that's helpful for things.
There's one final question, could answer it really quickly, potentially. I'll put it by you. So Andy has asked, how will links to specialist interfaces out with the county be managed? For example, in Derby City, the nearest specialist burns unit is Nottingham City Hospital.
Yeah, I mean, that links to point made earlier, Andy, about some of the broader collaboration we're doing with some of our other ICBs and sort of other counties in some of this work. So there's a whole raft of activity at the moment, particularly around acute specialised commissioning and how we best organise ourselves to make sure that patients, wherever they might need to travel to for more specialist centres and more specialist input, have that sort of coordinated, joined up approach, and some of the outcomes that we've all got set out in our 5-year plans can really be delivered. So a lot of work sits behind the scenes in terms of making sure that those specialist interfaces also come into play here as well.
Great, thanks, Zara. And yes, just to wrap up, as I know we're 1 minute past 2 now, but brilliant questions from everyone. So it's been a really informative and interesting session, and thanks, massive thanks to Craig and Zara for giving up their time to come and talk today in this session, and big thank you to Michaela as well for providing the BSL interpretation. We have got a couple of sessions planned for before Christmas. We don't have the detail of exactly when they are yet, but please look out for them via email, and they'll also be posted on our engagement platform. So yeah, hopefully we've got a few booked in before Christmas, and we're just in the process of planning for next year. So just a final thank you to everyone, and we'll see you next time. Thank you very much.
Thank you.
Thank you
very much indeed.
Thank you.
Thank you.